Greetings, champions of change. My name is Madeline Ballard, and I direct Community Health Impact Coalition, a team of community health workers and aligned health organizations making professional community health workers the norm worldwide by changing guidelines, funding, and policy. We are your hosts today, and I'm tasked with setting the stage for what will be an extraordinary briefing. I'm excited to welcome you all today because I sense that while we represent many organizations, we are united in belief that it is unacceptable for millions of community health workers globally, 70% of whom are women, to work without pay and support, that this endangers providers and patients, 1 billion of whom will never see a health worker, and that we, all of us on this call, know that the future is professional CHWs who are salaried, skilled, supervised, supplied, integrated like any other health worker into the national health system. So we yearn for a present characterized by quality of care for all, including those who provide it. Everybody on this call, more and more people, institutions around the world agree with us. Today, we're going to address how we move from the rhetoric of change, which is step one, to the reality of change. Our briefing today has 3 objectives. Next slide, please. Advise, align, and act. First, we'll review WHA76 and the relevant proCHW events. Then we'll share key advocacy messages and opportunities. And then finally, we'll close on concrete actions we can take collectively to move the needle at WHA76. Advise, align, and act. We'll be guided today by model collaborators and esteemed experts at their craft who've been brought together by CHIC's Director of Advocacy, Dr. Tessa Warr-Lawrence. Our panelists today include Dr. Salim Slim, the Director of Preventative Service at the Ministry of Health in Zanzibar. Next slide, please. Catherine Kane, Technical Officer at the WHO, and Dr. Dan Nsubuga, Africa Regional Health Director at TIP Global Health, and Claudia Shulimani, Vice President at Village Reach, Kose Makuya, CHW Advocate at Integrate Health, and James Nardella, Chief Program Officer at Last Mile Health. So we have an exciting opportunity for collective action ahead of us. As the premier global health policy-making body, the WHA is attended by representatives from WHO member states from around the world. And this means 3 things. 1, that together we can ensure proCHWs are given the attention they deserve at the highest levels of government. 2, the WHA is also responsible for approving the WHO's budget and work plan. This means that advocacy for proCHWs at WHA can help ensure that CHWs are included in global health policies, strategies, and that the necessary resources are allocated. Finally, as a major event with global reach, the opportunities for 3 networking collaboration at WHA can help broaden our partnership and alliances to support proCHW programs and policies worldwide. So, if you're going to remember one thing from today, aside from the names of our esteemed panelists, next slide, please, that I hope you'll meet in this upcoming week, it's this: that as a coalition of like-minded individuals on this call, more than 100 strong, we possess a distinct advantage to bring about change. By uniting behind a shared vision, by coordinating meetings and messaging with policymakers and government representatives, and by aligning media, we, on this call, can set the tone for WHA and make a strong case for proCHW policies at the highest levels of government. So, enough rhetoric, more action. It's going. I'm honored to pass them to Dr. Director of the. Thank you.
Thanks very much. I hope all our colleagues are on board. And on behalf of Ministry of Health in Zanzibar, first of all, I would like to to express my gratitude for being honored to be given this opportunity to speak to this important collaboration as a way forward to really cement the effectiveness of our community health worker as very important part of health system. I will be talking on behalf of Zanzibar as a context. Hopefully, through that we can able to mimic it and see how this impact can also be part of the model in other countries. Zanzibar has adopted a CHV, we call them CHV, but they actually CHW. And we really have seen the improvement in how we able to transform the service delivery right at the core of the primary healthcare where community are living. These are the trusted neighbor, and obviously they belong to the context that we pick them from, and their value that they are adding to us has hugely transformed on how we deliver care. For example, we have increased our health facility delivery for up to 57% from 33% within the gap of 3 years. But also our vaccine covering uptake rate has increased tremendously. Recently, Zanzibar has suffered a lot from measles, and for the use of CHV, because we are a very small island, we managed to go door to door after them doing the social sensitization. We went there and inoculate each and every kids that we managed to see. And now Zanzibar is totally measles-free within a period of less than 6 weeks. These are just one of the initiatives that our CHW has managed to help the Minister of Health. We now embarking on a serious problem on reduction of maternal mortality, and they play a key role on how this community are well sensitized in tackling 3 model delay in terms of service delivery from time of seeking care to the time of receiving care, but also understand that context nature that drive maternal mortality in Zanzibar, such as area of anemia, nutrition, and other facilities. We managed to see those data through their digital platform, that through their door-to-door innovation, we managed to see where the problem is and go with the right intervention, with the right pace, at the right context. And government of Zanzibar has really adopted and recognized the effort of this individual, but rather also we understand the contribution in partnership organizations such as D3, UNICEF, Farmer Access, and other CSO, who has helped us to sustain the current program and further professional CHV in Zanzibar. It's been 5 years now. We enjoy the modality of this individual, and we really argue that this individual, pacing the way that most of African countries and other low and middle income countries, has a huge gap on human resource capital for health. CHV seems to see the right modality that supports our healthcare delivery right at our community health. Our CHV here are very important part of the pyramid of referral. They are actually see the people first, and they taking care of them where there is a need for them to go into the health facility. They are the one that make the decision. This is how far we have managed to utilize it. And I think from what I've seen at the moment, their service they render is so huge compared to their reward they are receiving. And therefore we do notice a shortfall in terms of dropout of this individual because of the lack of consistent incentive that they really deserve if for the level of what they're doing. So I argue that our effort to anchor in utilization of our community health is so vital that if they are not part of the integrated health system, we will probably be very fragmented in terms of our service delivery. So I argue that a donor in relation to consider the CHW as very integral part of the health system and see the modality of supporting them. And I believe what has happened in Zanzibar, majority of the country will feel the same for the contribution of this important part of our healthcare workforce. And I therefore argue that we really need to find a modality to support them, salary them rather than incentive them, to ensure that these well-trained individuals, they don't disappear of the health system just because they've been offered incentive elsewhere. The fact that they are being paid low at the moment and still stay in the system show that they are passionate in terms of contribution they are willing to make. So I believe if we can create the right environment for this individual, our health system challenge, most of them will probably be a long distance history, especially in area of maternal health and associated area. But we also have observed the acceptance of CHV in other programs so that they help us to deliver minimum intervention package to the community, all of which contributing to improve the health and well-being of the people of Zanzibar per se, with a core value of preventive, but also promoting public health. With that in mind, I feel honored again to join you, and I look forward to close collaboration to ensure that this civic society, they play a big role in allowing CHV to venture as important part of health system, given the state of the serious gap of human capital for health. Thank you very much, guys. Thank you. I really appreciate it.
Thank you so much, Dr. Slim, for opening the event today. I think it's safe to say that if every government followed in the steps of Zanzibar, we'd all be in a much better place. So we're looking forward to making that the case, starting at WHA this month. And we're so thankful for your leadership and exemplary actions on the part of the Minister of Health. I'm pleased now to introduce Catherine Kane from the World Health Organization itself to share a little bit about WHA and situate us in this current moment.
So thank you very much. I'm delighted to join all of you. I have been a community health worker, and I have been an advocate, and I remain an advocate despite my current role. Now, what is the World Health Assembly? What many of you may not know is that at WHO, we have 193 bosses. They are the member states of the United Nations. So the way that member states, the way that countries tell us what they want us to do is by gathering at the World Health Assembly once every year in Geneva, Switzerland. They come and they say, this is what we want. Where do you fit in? Civil society organizations actually do play a role at the World Health Assembly, along with professional associations, in what's called a non-state actor status. So there are specific organizations that collaborate with the World Health Organization that are granted these status based on work that we are doing together to promote the goals of health. As you may know, we have the triple billion targets, which guide WHO work, and the triple billion targets for WHO are 1 billion more people benefiting from universal health coverage, 1 billion more people better protected from health emergencies, and 1 billion more people enjoying better health and well-being. So the World Health Assembly, what happens? Right now, we started off today, and for the next, for the 17th through the 19th, there is the program budget committee. This is where they tell us how much we spend. They discuss how much we should have spent, and they approve the proposed program budget for next year. This is pre-negotiated earlier in the year at the executive board meeting by a handful of rotating member states. What happens next? We talk about a set of issues every year. These are determined by year, and often I would highlight in our 75-year history. Yes, it is our birthday. Feel free to wish us happy birthday. This is our 76th World Health Assembly. Each year includes a set of issues. They're often within those a set of issues that concern specifically the health workforce ever since the Health Workforce Department was created out of what used to be an association of interested parties. One of our principal and foundational World Health Assembly resolutions. So sorry, I stepped forward there. A resolution is when member states review a given set of information, and then they come forward and it's sponsored by one or more member states and written by one or more member states. And it says, recognizing that, understanding that, viewing that, and it provides a set of evidence, a set of validated scientific peer-reviewed information that says this is what the situation is. And then it goes forward and says, we therefore endorse, we support, we promote. And they come up with a set of really interesting words, each of which has a very sincere meaning. Some of them mean, we like this, but we can't pay for it. So we are going to say that we support the idea of it, and it might be not binding. If they say we agree to this, and there are many, many words that say this, then it says this is binding. We agree that we are going to move forward in this way, and we'll allocate resources to ensure that we are supporting any member states who actually do need support in implementing. So foundationally for the health workforce, we have what's called the Global Strategy on Human Resources for Health, Workforce 2030. That is our view from 2016 to 2030 on how we're going to achieve the Sustainable Development Goals using the most important element of a health system, which is what in World Bank terms we'd call human capital. What do I call them? Health workers. What do you call them? Us. So we are part of a larger group. As the community health workforce, we are part of and connected to a larger group. What governs the conduct of what we do is the Global Strategy on Human Resources for Health. That was followed by a high-level commission that looked at health employment and economic growth. So it recognizes something that's really fundamental to human resources for health, the health workforce, which is that we're not alone. Never anything that we do should we be doing alone. And you'll recognize that very much as members of and representatives of community health. We are surrounded by education, which helps us produce the workers that we need, by health, obviously, because that's what we're working towards, by labor. If you educate people to produce health, you need to be able to employ them. So by jobs, by finance. You can't do anything unless you pay. And I know that that message is very clear to all of you. And I would also say that the final one that's a really big portion of what we do is equity. And that is whether it's disability, gender, or any other characteristic of a health worker, we believe in advancing equity, not only for health workers, but through health workers for health for all people. Let's see, what was it? 3 years ago, we had the International Year of the Nurse and the Midwife. We also had in 2018, I bet many of you know this, but what I think it is a really central resolution that guides what we do, which is community health workers delivering primary health care, opportunities and challenges. You know what I've spoken more than I should have, but what I'll close with 3 more key elements. 1, the Community Health Worker Guideline, launched in 2018, was the first of its kind. It is the first time we all sat down and we said, not only do we recognize community health workers as really key members of the health workforce delivering primary health care, but we also say that we want this guideline in every member state. Dr. Slim actually talked about all of the changes and all of the improvements that they're implementing in his country. And the Community Health Worker Guideline is the hook for all of the work that we're doing. It's the hook for absolutely everything that's community agrees on and has brought forward. And I would argue that it's both member states and civil society and health workers themselves who have brought forward the Community Health Worker Guideline. In 5 years, we have come such a long way. Never is there a conversation that doesn't recognize the guideline. Never is there a presentation where we don't trip over ourselves to find new ways to say what we're all saying, because we agree so violently, so cohesively, that there is a pathway forward for community health workers. So moving beyond that, we also had 2 years ago a resolution that says we believe that we need to protect, safeguard, and invest in the health and care workforce. The member states told us at WHO, we want a care compact to ensure that we know how to and what the legal basis is protecting health workers. So last year, what did we do? We presented the Global Health and Care Workers Compact. And I have the great privilege of following up on my work guiding the CHW resolution to now guiding the Global Health and Care Workers Compact, which is guaranteeing that we protect you, that we provide decent work, that we ensure that there are resources available to do your work, that we ensure inclusivity, that we prevent harm from occupational health and safety to violence in fragile conflict and violence contexts. We are sitting there working for you as part of the global health workforce to bring these issues forward. And I would say that the last thing that I want to tuck in here is, as we advocate at the World Health Assembly, it is very important that we recognize that we are part of a team to protect, invest together in the health and care workforce. What this means is we understand that we are integrated with nurses, with doctors, with lab techs, with pharmacists. We all need each other to do our work. We need to bring all of the health workforce together so that we together gain some successes. So just to finish, protect, invest together is our hashtag. WHA76, the other hashtag. Let's bring this forward together. Really looking forward to talking to you. And I'm stopping.
Thanks so much, Catherine, for setting the stage and letting us know, for those who may be unfamiliar, why WHA is so important, and also what some key milestones of the journey so far has been. As you've said very well, more and more people agree with us. Now it's time to move from affirming a guideline to affirming a budget. So for more on that, I'm proud to introduce our next speaker, Dr. Diana Nzubuga, Africa Regional Director, TIP Global Health.
Thanks, Dr. Madeline. Hello, everyone. My name is Dr. Diana Nzubuga. I'm the Africa Regional Director at TIP Global Health, and I'm a proud member of the Community Health Impact Coalition. At TIP Global Health, we prioritize a well-functioning primary care ecosystem that includes a well-integrated community health workforce. Discussions through the World Health Assembly often speak about community health and community health workers in abstract terms. Throughout collective advocacy, we will focus the eye of the World Health Assembly on the crucial role that proCHWs play in the global health architecture. I'll be guiding us through the WHA agenda items relevant to our shared proCHW movement and why we should engage at the World Health Assembly for the inclusion of proCHWs to ensure health for all. This year's World Health Assembly agenda has many items of interest to us as a coalition. However, based on the advocacy channels open to us as a coalition, we'll focus our efforts on 3 areas under discussion. One of them is the global strategy for women's, children's, and adolescent health that is within the time period of 2016 and 2030. We'll also speak to the universal health coverage, and lastly, the strengthening of WHO preparedness for and response to health emergency preparedness, response, and resilience. Firstly, the WHO's global strategy for women's, children's, and adolescents' health is the first thing that I want to really focus on for our conversation today. Indisputable evidence shows that community health workers play a very central role in providing preventive, promotive, and curative health care to women, children, and adolescents. Community health workers carry out many complex health tasks, such as the promotion and provision of good nutrition, delivering immunizations, promotion of health household behaviors, and appropriate utilization of health services, diagnosis and treatment of acute neonatal and child illnesses, and the provision and promotion of safe water, sanitation, and hygiene practices. Their clear impact is not well reflected in the global strategy and its implementation, which largely pays lip service to the role of community health workers in providing these essential services. With 54 countries falling behind on their Sustainable Development Goal targets on newborn and child health, the World Health Assembly is seeking guidance on the priority areas to ensure health for all newborns and children. Let's make sure that pro-CHWs are a central part of our agenda. Secondly, we'll focus on universal health coverage and the United Nations high-level meeting on universal health coverage in September 2023. We all are aware that the political declaration on universal health coverage published as an output of this high-level meeting will serve as the North Star for health for all in each of our countries. We have been engaged in this process since the beginning of the year, conducting collective advocacy to influence the inclusion of pro-CHW priorities in the process, sending advocacy letters to the United Nations country delegation and the honorable ministries of health, and speaking on the floor of the United Nations multi-sectoral hearings on universal health coverage. Our efforts have been successful. You may be aware that the original documents responding to only 2 of our 8 pro-CHW best practice priorities. Currently, the process at least includes 5 of our 8 pro-CHW priorities. But we must not relent. As governments prepare for negotiations on the political declarations on UHC on June 1st to 2nd, we must continue to act as a coalition to ensure that pro-CHW priorities are maintained as a core part of health for all. Finally, let's turn to the agenda item on strengthening the World Health Organization preparedness for and response to health emergency preparedness, response, and resilience. We know that community health workers are vital in detecting disease outbreaks, supporting emergency response, as well as maintaining health services during public health emergencies. They not only help prevent health emergencies, but they also maintain health service equity and access during emergencies. Community health workers can blunt the impact of health system shocks. In fact, CHIC research found that well-supported, protected, professional community health workers maintained access to care for 5.2 million patients during COVID. The zero draft of the World Health Organization instrument on pandemic prevention, preparedness, and response mentions strengthening of training, deployment, remuneration, distribution, and retention of health workforce, including community health workers. The World Health Organization noted in a report, I quote, "There is no longer any question of whether community health workers can be key agents in improving health. The question now is how their potential may be realized." I'm really looking forward to the collective action we can take to advance the pro-CHW movement and make sure that every community health worker program is set up to succeed as the World Health Organization seeks to develop a plan for the global response to future health emergencies. Without further ado, ladies and gentlemen, I'm truly honored to pass over to Claudia Shilumani to discuss more about how we can be able to do this.
Thank you very much, Dr. Diana. My name is Claudia Shilumani. Oh, let me put on my video. My name is Claudia Shilumani, and I'm the Vice President for Partnerships and Impact at Village Reach. We ensure that we support universal health coverage through improving the last mile, as well as supporting government to implement digital solutions and support the work of CHWs in the countries that we have presence in. It is my pleasure to be here. I recently joined the CHIC Advisory Board as a member representing the coalition members. As outlined by Diana, there are three main areas that we'll focus on with this year's World Health Assembly. And I will be leading us in thinking through how we can collectively advocate for the meaningful inclusion of community health and CHWs at the World Health Assembly 76. WHO strategy for women, children and adolescents health 2016 to 2030. Member states have been asked to provide guidance on the specific priority areas for action in three areas. One of them is increasing investments to accelerate progress on newborn and child survival. There's also a need to inform WHO strategic approaches to support health for all women, children, and adolescents, as well as support for member states on adolescent health. Our objective here is pretty simple. We want to ensure that country delegations speak to community health and pro-CHWs in their statements to the WHA in order to center pro-CHWs in the WHO's priorities for the global strategy on women's, children, and adolescents' health. We have collectively worked on a one-pager to share with country delegations, which outlines the vital role pro-CHWs play in newborn and child health. In this one-pager, we outline the following calls to action for country delegations and the WHO. Champion country leadership in quantifying, promoting, and progressively expanding funding allocations towards community health. Commit to funding clear, costed, and prioritized community health strategies focused on ensuring that all children receive their routine vaccinations on time and in full. Develop and maintain a WHO database of up-to-date global health workforce statistical data on CHWs as core healthcare providers. And lastly, expand the WHO's digital health interventions taxonomy by using a digital adaptation kit for community health information systems. This one-pager is available online in French and in English and will be shared after this briefing too. Printed copies will also be available in person for those in Geneva and with access to country delegations. Tessa, who is the CHIC Director for Advocacy, will be coordinating this effort, and please do reach out to her via email to get involved in this action. The second part is the UN Political Declaration on Universal Health Coverage. As Diana has already outlined, the contents of the zero draft for the Political Declaration on UHC will be announced at the WHA. We are working very closely to see whether pro-CHW priorities are maintained. As she mentioned, we had 8, 5 made it into the declaration. We want to make sure that those are maintained. As CHIC, which is a member of coalition members, allies, CHW advocates, and pro-CHW supporters, we should collectively share pro-CHW messaging in our framing of health for all. We urge those of us with contact with ministries of health and WHO country delegations to sign and share the pro-CHW letter, which we develop with communities at the heart of UHC Coalition and the Frontline Health Workers Coalition. Share this with country delegations in the run-up to the political declaration negotiations starting the 1st to the 2nd of June. And again, please reach out to Tessa via email to get involved in this action. Most importantly, we should continue to socialize the Monrovia call to action, which came out of the 3rd International CHW Symposium in Liberia as a core part of our advocacy. The Monrovia Statement advocates for health for all with a focus on strengthening community health systems to improve access to primary health services. It sends a clear message on the actions needed to achieve health for all. Let us use it as a clarion call for pro-CHWs. Social toolkits and relevant links, including the pro-CHW one-pager, will be shared after this meeting to support us all in this action. Now, the last part is on the pandemic prevention, preparedness, and response. We know that pro-CHWs help prevent health emergencies and maintain health service equity and access during emergencies. So far, the power of our radical collaboration across a number of coalitions has ensured the inclusion of CHWs within the WHO Accord on Pandemic Prevention, Preparedness, and Response in February. But we cannot lose momentum. We must advocate to ensure that pro-CHWs are considered as a key constituency within pandemic prevention, preparedness, and response. The WHO has embarked on a process to develop a global convention on pandemic prevention, preparedness, and response by next year. Our objective during the WHO is simple: to use our collective presence at the WHO to identify key stakeholders, decision makers, and advocacy windows to ensure that proCHWs are included in the planned Convention on Pandemic Prevention, Preparedness, and Response. Again, TESA will be coordinating our efforts during WHA to crowdsource information on members of the drafting team for the Intergovernmental Body on Pandemic Prevention, Preparedness, and Response for targeted advocacy. Reach out to her to get involved in this action. We know that investing in professional CHWs who are salaried, skilled, supplied, and supervised is vital for achieving health for all. And it is at WHA76. We can combine our advocacy skill to put proCHWs firmly on the agenda for country delegations and the WHO. At CHIC, we live by the notion that nothing about CHWs without CHWs. So it is my privilege to hand over to Kosia Makoya, a community health worker with Integrate Health, to hear why these actions mattered so much. Kosia, over to you. Kosia.
Super. D'accord.
Okay. Thank you for giving me the floor. And good morning to all of you. My name is Makuya Kosia, and I am a community health worker in integrated health since 2018. I'm very happy to participate in this conference online. When you talk about my work as an CSW, and to talk to you about the importance of defending professionalized CSWs. Before I begin, let me tell you a story of one of the patients that I took care of in my community. Indeed, I was actively searching, as I do every day, when I chanced upon a woman with 4 children. When I asked to see the kids, she showed me 3 and she hid the 4th. By dint of insistence, she told me that he was in pain and was sleeping. After various explanations, she finally brought the kid in, whom I examined. That child was 2 and had a fever of 38 degrees Celsius. And that kid couldn't stand up. After a TDR was positive, I gave him paracetamol. The mother refused to go to the clinic because she didn't have any money to pay for care. We must note that the husband had gone off on an adventure, and he and she had to get by to protect the survival of the family. So I brought the child to a center where he was able to get free care. I continued to follow up with the child for 3 days. And now that child is really doing well and can attend school in the village. Every day that I spend at home, the mother never stops thanking me, because 2 years ago, she lost a kid under the same circumstances before the program existed. I'm very proud now because through my work, this child has been saved. And many others in my community, based on the story that I just told you. I would like to say that having professional CSWs having us recognized as medical workers who have the necessary material and being properly compensated. Without such workers, this kid could have seen his health degrade and he might have even died. Before I became a community health worker, I saw women and children died because they didn't have access to care. But thanks to our work, these cases are no longer ignored. This is not the case anymore in my community. Thanks to community health workers and thanks to the care that we offer people in their homes, we are in a position to save lives like this because we are recognized and we are equipped as professional health workers. We are an expansion. We are an extension of the health centers in our communities. We bring free healthcare to the homes, which resolves the issues of distance for the community. We recognizing us and equipping us as other health workers is an essential part of the development of primary health care and has an impact on universal health care that the underprivileged deserve. I believe that we can continue our advocacy by continuing to raise our voices wherever decisions regarding CSWs are made and wherever decisions on primary health are taken. And I would like to take this opportunity to thank, the connection, by making the voices of CSWs heard throughout the world. We need greater visibility for the work of professional community health workers. Thank you so much.
Thank you so much, Kasia.
Merci à vous aussi.
Thank you also.
We, on that note, want to move to questions from the audience. How do we take the strategy that was just outlined by Diana, Claudia, and Kasia and put it into action this month together? We're here to answer your questions and to moderate that discussion. I'm proud to introduce the Chief Program Officer of LASMA Health, a founding coalition member, James Nardella.
Thank you. I thought as we start into our question and answer, we would start with Kasia as our community health worker who's spoken on the panel. So Kasia, I would just want to know, I'm hearing the work you're doing to help children and women survive and thrive in your community. If you were the boss of the community health worker program, what change would you make to improve the program?
Yes. I didn't really understand your question. Please.
If you were in charge of the community health worker program, if you were the boss lady, what change would you make to improve the program?
Oui. Oui. D'accord, merci pour la question.
All right, thank you for that question. If I was the head of the program, I would take care of the CSWs. First of all, equip them further. I would pay them as they need to be paid, to encourage them. And since I talked about equipment, if we're equipped and we have all the material to go out into the homes and into our communities, we are constantly going to save lives, which encourages and motivates community health workers. It's saving lives. What encourages us to do that is have the necessary equipment, material, and the proper compensation, an acceptable compensation that will help and that will encourage the CHWs to work properly. Thank you for that question.
Thank you. It's really helpful to hear what you would prioritize. Here is a quick question that came in the Q&A, and Catherine Kane from WHO, I'm going to direct this to you. You talked about the Workforce 2030 as a key statement, a key stance. There's a question in the Q&A about, do nurses have a stake in the efforts to get pro-CHW policies? So would it be of interest of nurses to see pro-CHW policies adopted, Catherine?
It is in the interest of every health worker to have a team. None of us do our work independently. None of us do our work without supervision. None of us do our work without people helping out. So it is absolutely in the interest of nurses to advocate for community health workers that are recognized by the system, that are consistently supplied to do their work, that are offered educational opportunities to improve the work that they do, that are paid to do the work that they do. It is in the interest of nurses, when CHWs are recognized as a formal part of the health system, to ensure that nurses, who are often the supervisors, are paid for the visits they do to CHWs. Those visits are to support the CHW in ensuring that they're providing good health. Those visits are to ensure that CHWs are supplied. Those visits are to collect and share back data. So when a nurse comes to a community and visits the CHW, she is conferring on the CHW the recognition of the health system. She is bringing back information to the leaders of a village, of a town, of a city, and saying, this is the difference that was made when the CHW program was impacted. This is the difference that we're seeing in the number of women and children that are surviving. This is the difference we are seeing in the number of people who are getting vaccinated. So that integration with the system is to absolutely everyone's benefit. And all health workers, when they work together, are more successful as a team.
Thank you, Catherine. It's helpful to hear your perspective there. Dr. Slim, there are some questions that I think would be great to hear your opinion on in your experience from Zanzibar. You talked about the importance of salaries for community health workers, not just incentives. So can you tell us what sort of compensation scheme is in place in Zanzibar? And as you think about this journey towards fair pay for CHWs, where do you see progress and where do you see support that's still needed in Zanzibar?
Thanks very much for the question, James. In fact, we do have approximately 2,400 CHP in Zanzibar, and each one is responsible for approximately 700 households. They do go door to door, they understand the context of the community, and if there is any issue, they are the only people that can actually arouse to the system they will flag it to the system for us to be able to respond. And there have been incentive for approximately, say, about $25 to $30 every 28 days, which is really a small portion of money compared to the living standard of Zanzibar. And to be honest, it has not been tally up with the effort that they are putting in trying to support the health system. And we have a lot of dropout. They do tend to go away to other jobs to ensure that they sustain themselves. And then by the time they come back, they will miss a lot of training. But these are the individuals that we have invested already in trying to understand the problem in the community and help us how to resolve them. Yeah, like I say in the previous, they are at the bottom of the pyramid of the referral system, right? So they actually work very well just before a client go to the healthcare service. They are the people that they are encounter with. So I think at the moment, the modality that is there is not really conducive to allow them to be sustained, yeah, in terms of their contribution and long-term partnership with health system. So we do require a mechanism in different partnership, in seeing probably from global fund perspective, to see how we can able to provide these people the salary rather than incentive, so that they are established in the system and they stay with us as long as they know they are integral part of the health system, rather than people who are being called whenever they are needed. You know, and their service really has shown us effect. In Zanzibar alone, we have at least 52% deficit of healthcare workforce, right? And we can't really assign a nurse to do some assessment in other clients. So nurse can able to deal with other parameter, while CHV, after they receive training, they can able to complement this non-biomedical intervention that the nurse could have done otherwise. So you can see how much they kind of complement our service delivery. So I believe if we correlate together and try to see the modality from financial contribution to ensure that we can sustain them from partner, for example, we in a negotiation in our global fund write-up, we put a lot of issue on relation to how we can able to salary this individual, but we really still looking out for opportunity to see how well we can establish a funding mechanism to ensure that they are salaried, but also we need to increase their number, because one CHV for 700 a household is too much. It's too much work pressure on him, and maybe we require to do at least 350 households. So we require to double the number, but we can't afford it based on the pass that we currently have. But this individual should really have the recognition they deserve as a serious part of the frontline workforce of any health system, most likely low and middle income country. Thank you.
Thank you, Dr. Slim. It's helpful to hear your experience, and I'm sure that there are many on the webinar today who are dealing with similar dynamics. Maybe to stay on this thread for a little bit, Dr. Diana, I want to pull you in. There's a question in the chat in the Q&A that says, countries may say we would like to go to pro-CHW policies, but we do not have the money. Are there any steps we can take to expand the fiscal space for countries to move forward in the way we want? So building on Dr. Slim.
Great question, James. Thanks for asking, and thanks for the person that has asked. I just want to put two key nuggets here. That the first step to advanced investment is countries thinking about, do they have community health strategies as key policy documents that can embed in community health workers as a critical cadre for health? And once they have a community health strategy, the next step would be thinking about an investment case for community health program. And the investment case is a key tool that governments and countries can use to mobilize resources, both domestic resources to their ministries of finance and ministries of health, but also mobilize resources from their development partners, donors, among others. And so it's very critical as we're moving ahead for governments to not leave this agenda for partners. But governments need to take a roadmap to say, how are we going to invest in our community health worker program? I've seen many governments take on a phased-on approach to make this possible, but it starts from a strategy to an investment case and to critically thinking about a roadmap to sustaining and investing in their community health worker program. Over to you, James.
Thank you. It's really, again, I can see in the questions and answers, the energy that we have around how do we finance these programs. Certainly that is one of the major questions that we should be all wrestling with and bringing great ideas to WHA. I also see questions that we haven't had a chance to answer on CHW training and recognition and standards. Maybe if we can take some of those questions offline, we'll do our best. Just to move us forward as we close out the webinar today, I want to thank everyone. It's been great to have your time and attention. If we can go to the next slides. What's next? There are some things that we can all do. If you are in Geneva, you can meet your country delegation contacts to share our calls to action. The calls that you heard today on women, children, and adolescent health, on the pro-CHW priorities, or the way that CHWs are connected to UHC. You can leverage your networks to find out more about the key players and advocacy windows on the Pandemic Preparedness and Resilience Accord. If you're in Geneva, please email Dr. Tessa, who has been hosting this call today. Please email Dr. Tessa by Sunday. Her email will be in the chat if you plan to be in Geneva, so we can coordinate our approach and make sure that we hand you some advocacy tools. If you're staying home, you can share the CHIC WHA calls to action on your social media. You can reach out directly to stakeholders in your countries to share those calls to action. So thank you, whether you're in Geneva or whether you're participating from afar. There is work to be done to further our joint goals of professionalizing community health workers, making sure that they're salaried and supplied and supervised and skilled. I know that many on this call are a part of that movement, so thank you.
Thank you very much. Thank you, James, and thank you, everybody.
Thanks, everyone.
Thanks all. See you next week, online or in person.
Thank you and good luck at WHA.
Thanks, everyone. Thanks for having us. Bye-bye.